So, good afternoon, everyone, and welcome to our annual finance update for GP practices. It's lovely to see so many people have joined us again this year, and welcome to all those who are joining for the first time. My name is Kay, and I am Head of Healthcare here at Duncan and Topless. We've got a dedicated specialist team to support our practices, ranging from services to act as a virtual finance manager, bookkeeping services, accounts, taxation, pensions to multi-million-pound property deals and allowances claims, as well as VAT, PCN and Federation business services, and any other healthcare GP-related business services or collaborations. Today, I am going to be running through the contract changes and network contract changes for 2026-27 before moving on to my usual tips, hints and hot topics section. Can I please just ask if you have any questions as we go through the session, please do note these in the chat section and I will respond at the end. There'll also be a feedback form sent to you shortly after the event, so if you prefer, please do pop any questions there. I have also put my email address in the Q&A section. So for anybody that doesn't already have my email address, you've got it there. And if you do want to contact me directly or by telephone, of course, please do feel free to with any questions you might have. Okay, so today we are going to cover the review of the key areas of the GMS contract changes. We're going to have a review of the PCN income changes, national living wage increases, and as I say, the tips and hints and hot topics section at the end. So GPC England was unable to negotiate the contract with the government, and 98.9% of respondents in the recent referendum around the contract imposition voted to reject it. There is a meeting between GPCE and government on the 30th of April. The letter sent out to practices advised that the new contract is designed to build on the changes made over the last few years in respect of improved access and focuses on GP capacity, supporting the shift from treatment to prevention. And the letter stated that an additional £485 million would be invested in the GP contract, bringing the total investment to £13,863 million. 3.6% cash growth, 1.4% real terms growth relative to the GDP deflator, which is a measure of the price level of all domestically produced goods and services. This originally included a pay assumption of 2.5% for 2026-27, which we hoped would be revisited once the DDRB released their recommendations, and they actually released that recommendation of 3.5% much earlier than the usual June or July, meaning that the extra 1% was incorporated into the global sum figures that we'll see ahead of the 1st of April. So there won't be a mid-year uplift and backdated amount this year. It is worth noting that the same 3.5% uplift has been applied to the maximum reimbursable amount for the Rs GPs too, and the locum reimbursement rates. Other Rs staff will receive a total pay uplift of 3.3% in line with the agenda for change recommendation by the NHS pay review body. Whilst mentioning staff-related uplifts, confirmation has not yet been received in respect of what uplifts would be applied to educational allowances, GP trainer grant, GP fellowship funding and GP educator scales. Dispensing fee scales will be uplifted in the normal way in October 2026. The recommended increases relate to salaried GPs, and whether you are legally bound will depend on the contracts, but it is highly likely most of you will have to due to the contracts that they will be on. DDRB uplift recommendations are for salaried GPs, not for all staff, although they encourage practices to implement pay rises in line with the uplift in funding they receive. So remember that the uplift in funding is based on weighted patients and a proportion of your core contract sum, not on your staffing costs. And that uplift also has to cover on costs as well. So it is a complicated calculation. And the key thing is looking at what you need to do to retain your good team members, but in a way that is affordable. We have recently carried out a salary survey, although uptake has been much lower than expected. If anyone does want to take part that hasn't already, please do drop myself or your usual contact and email for the link to that. If you don't already have it, we have extended closing that to tomorrow evening. So back to the contract changes. They also include additional funding to support the QOF changes, as well as to support cost growth, including premises cost inflation. The 485 million includes 416 million into the core contract and 69 million into the PCN DES. And the core themes remain consistent. So reducing health inequalities, improving patient access and extra appointments, continuity of care, so bringing back the family doctor, delivering patient care closer to home and around communities, prevention of disease, reducing waiting lists, and use of digital technology and data. With a strong focus on delivering same-day access for clinically urgent patients, the 2026-27 GP contract aims to support GP capacity. £292 million of funding has been moved from the PCN capacity and access payment to the GP contract as a new practice level GP reimbursement scheme. This can be used to recruit additional GPs or to fund additional sessions from existing GPs to support the clinically urgent same-day access changes. Capacity and access has been removed from the network contract DES, so it will depend on how this money was being used within the PCN or distributed as to how this will impact your individual practice. And you need to look at this carefully and work out the impact to support your cash flow and budgeting for 2026-27, especially as it appears that the funding will be paid in arrears, so after the costs have been incurred, thereby impacting your cash flow. As you may have read, NHS England plans to use the CQRS system for claims, and more information is to follow. It looks like the hope is for things to be up and running in May and back claims to be made at that point as necessary. It's also worth noting that if your practice is deemed to have a high GP to patient ratio, so over 3,000 patients per GP, you need to get ICB approval to access the scheme. Once again, the details have been lacking, with only headline changes released on the 24th of February, and the updated SFE was only released on the 31st of March, leaving practices no time to plan ahead. Of course, it will still have to be amended for the GP reimbursement scheme. I have already mentioned that patients deemed by the practice to be clinically urgent need to be dealt with on the same day. For those assessed as non-urgent, the practice needs to ensure that they have made contact before the end of the following core hours period to at least let the patient know how their issue will be managed and what will happen next. Where this doesn't happen or there are issues, practices will need to engage with their ICB. So it's really important to not only understand the funding changes, but what impact these requirements have on your staffing need and ultimately costs. Other changes include advice and guidance becoming part of core contract. So when looking at the uplift to core contract, you do need to take account of the advice and guidance payments you were receiving but will no longer. This was brought in last year and was worth 80 million. 82 million has been transferred into the global sum for this. The aim is to reduce referrals into secondary care and therefore waiting lists. With it now being part of the core contract, it will reduce some administration, but will of course be based on weighted patients. So again, will impact practices differently depending on patient need. So what do the main changes mean for you and your practice? Let's start by looking at the practice level changes. So global sum had initially increased from £112.50 to £121.79 last year, but that was then uplifted further to £123.34 with a backdated payment following the DDRB publishing their recommended uplift. This year we see an increase to £130.07, and as mentioned earlier, this is the final uplift as the DDRB recommendation has come out in time to negate the need for that mid-year increase. So that's an uplift of £6.73 or 5.46%. But practices will see changes elsewhere, as I mentioned, the loss of advice and guidance income, now that it's being pushed into core contract. GMS out of hours deduction has been 4.75% for quite a few years now, but that drops to 4.7% in 2026-27, and that's to reflect the advice and guidance income being transferred to core funding and not being subject to an out of hours deduction. Overall, the out of hours deduction does increase, obviously, due to the core contract sum increase, and that's to £6.11 from £5.86, which is relevant to any PMS contracts we have left out there. In 2026-27, there is to be no change to the weighting formula because the Carhill formula review is still ongoing. Adjustments for not providing minor surgery remains at 0.6% of global sum. There has been an increase in the value of a QOF point from £225.49 to £227.95. But if we then take into account the CPI uplift from 10,184 to 10,295, if your weighting has stayed the same and you achieve the same points, your money has not increased. It works out to be the same, as it has for quite a number of years now. QOF is being refined and looks at more clinically effective care, as well as becoming more aligned to the updated NICE guidance. There will be 18 more points up for grabs, so a total of 582 achievable this year compared to 564 last year, and the extra ones are intended to enhance clinical outcomes, modernise the scheme and ensure that the indicators reflect current evidence and best practice. The 18 points are worth around 25 million, and the focus is on priority prevention areas, including 2 new obesity targets to support referrals into weight management services. This will include delivering weight loss jabs, and the previous weight management DES therefore disappears. Practices will be rewarded for progress made towards childhood vaccination targets, so meaningful and sustained improvement in vaccine uptake. Often practices in deprived areas struggle to meet the targets and miss out on earnings. I mean, I do feel the wording is such that it isn't helping those who really try. There really is only so much you can do, isn't there? Updating the childhood vaccination indicators to reflect the introduction of the MMRV vaccine. The RSV vaccination programme is extended to all adults aged 18 and over and includes older adults in residential care homes. All eligible care home residents to be offered seasonal and routine vaccinations, and PCNs, although not necessarily carrying out the vaccinations, will be responsible for arrangements to encourage collaboration between practices. It's introducing a new diabetes indicator requiring delivery of all 8 NICE recommended care processes. Updates to the heart failure indicators to reflect the NICE recommended 4 pillars of treatment, streamlining by combining and simplifying existing measures. And just a reminder here of the importance of the adjusted practice disease factor, which is your practice disease prevalence divided by the national average disease prevalence for a particular chronic disease. And it's very important for maximising your QOF money. The higher the prevalence, the better, so very important to make sure you have everyone registered correctly for each chronic disease. Personalised care adjustment. This allows practices to differentiate between a few different reasons for adjusting care and removing a patient from the calculation. Applying a PCA to the patient record will remove that patient from an indicator denominator if the QOF-defined intervention has not been delivered. It will not result in patients being removed from the disease register or other target population, and this mechanism differs from exclusions. There are strict do's and don'ts around what and how to apply these, so you have to be very careful, but ultimately these also impact your income, so do make sure you have gone through the information thoroughly and don't miss anything. COVID-19 and adult flu service specs have been combined into one document and published for 2026-27. So eligible cohorts for the COVID-19 Spring 2026 programme are adults aged 75 years and over, residents in care home for older adults, individuals aged 6 months and over who are immunosuppressed, and vaccinations should have begun from the 13th of April and end on the 30th of June. Priority should be given to care homes for older adults and eligible housebound patients. They have yet to announce the detail for the autumn campaign. So practices can now deliver these directly, and all eligible patients must be offered a COVID-19 vaccination. Practices can use the general practice information technology to record COVID-19 vaccinations and claim via CQRS. They will no longer be using point of care systems or the Manage Your Service system to claim for payments in line with other vaccinations. The £10 per housebound patient goes, but the COVID fee will be £8.70 per vaccination administered during flu season and £10.06 outside of flu season. So plan your campaigns to maximise any surpluses and to watch what you're doing with the staffing costs. If you signed up to deliver COVID, you have to deliver flus. You can, however, just deliver flus. Just a note there as well that the Learning Disability Health Check Scheme payments remain at £140. There are uplifts to the locum reimbursements. So you can see there the locum reimbursements parental, £1,475.17 for the first 2 weeks, and then £2,238.03. Sickness, £2,238.03p per week from week 3 onwards. And then the rates for prolonged study leave and suspension of £1,460.56 per week. They had forgotten to uplift the sickness figure in the SFE. It is the same as parental leave and has now been corrected if anybody had seen the rates when they were initially published. Just a reminder that you can claim reimbursement not just for locum cover, but also if a salaried GP or a partner is covering, providing that they're not already working full time. This isn't prorated, so good for people trying to cover a part-time worker, but not so good where you are trying to cover someone who carries out more sessions, as the reimbursement may well still not cover the costs. And we do see practices planning staffing and staffing sessions around the thought process of what they could get covered if anybody does go off. Before we move on to that slide, just a quick note there as well. The GP retention scheme continues with a payment sitting at £76.92 per session, up to a maximum of 4 sessions per week, and practices will also be paid the professional expenses supplement of £1,000 per annum for each session per week they work. That has to be passed on to the GP to cover their indemnity, CPD, and any other professional expenses that are eligible. And it does need to be processed through payroll with the tax and NI deducted. The GP can then claim tax relief on any allowable costs incurred. The Flexible Careers Scheme continues for part-time GPs who are eligible, and their first year in the scheme attracts a payment of 50% of their salary plus on costs, year 2 25% and year 3 10%. Also an education reimbursement to cover sessions and travel. Moving on, the network payment, so that's for participating in a PCN, will remain the same at £1.76.1 per weighted patient. There are also some other changes noted that I'll just quickly skim through. So certain metrics will be measured to help understand demand and improve services, and these will include call waiting time between 8 and 10 a.m, call waiting time during core hours, percentage of clinically urgent as determined by the practice seen on the same day, percentage of non-clinically urgent seen within 1 week, and percentage of non-clinically urgent seen within 2 weeks. Practices will be required to share data with the lung screening, cancer screening programme to support its operation. Online registration must be used in all registration cases, and practices will be required to enter information from paper registration forms into the National Online Registration System and ensure that changes to practice boundaries submitted through NHS England's digital catchment tool are approved by the ICB. Practices will need to reconfirm the nominated pharmacy whenever a new prescription, not a repeat prescription, is issued, and to ensure that referrals and triage tools used for community pharmacy clinical services offer patients a full choice of providers. Most practices will already be doing this. Practices must have a dedicated monitored email address, and it will be for receiving information from community pharmacies in the event that GP Connect is unavailable, and for new or emerging pharmacy activity that is not yet supported through GP Connect. So, for example, independent prescribing in community pharmacy. The email address must be kept up to date and shared with the Directory of Services. Existing practice email addresses can be used. This email address is intended to act as a safety net where the GP Connect route may be unavailable. The idea is to strengthen patient safety and ensure timely transfer of information. Another change is extended the GP staff survey to all practice and PCN staff. Practices are expected to engage with support from the ICB where there are performance issues, and this includes where practices are not meeting their requirement to see all clinically urgent patients on the same day or are at risk of contractual breach. PMS regulations will be updated to mirror the GMS regulations as usual. Finally, all practices must display opening times for all modes of access, so that includes walk-ins, telephone and online consultation on their website, in their practice leaflet and within practice premises. As a minimum, this must be core hours for all types of access. Looking forward to next year, with the implementation of the Neighbourhood Health Framework from 2027, practices need to be discussing longer-term strategies and further collaborative working. It is essential you get advice from specialist accountants and solicitors early on in the process of discussing the structure and mechanism of how you are looking to work in order to protect yourselves. We all remember the VAT and tax issues that PCNs brought with them, which brings me nicely on to the PCN updates. So going straight into the figures, your enhanced access payment has gone up from £8.42.7 to £8.90.3, and that's multiplied by the PCN's adjusted population as at the 1st of January 2026 and is paid monthly. Your core PCN funding has increased from £2.99.9 to £3.05.9. £2.31 of that is being multiplied by the PCN registered list size at the 1st of January 26, that's the fixed component, and 74.8 pence is being multiplied by the PCN adjusted population at the 1st of January 2026, so the weighted component. The capacity and access, as mentioned earlier, has now been removed and rerouted directly to practices with the new GP reimbursement scheme. PCNs and federations currently using the capacity and access payment at scale level will need to review this carefully within their budgets. This is a loss of funding for PCNs of £4.58.3 per adjusted population. A PCN's additional rolls reimbursement sum equates to £27.66.8 multiplied by the PCN contractor weighted population as at the 1st of January 2026 compared to £26.63.1 last year. And finally, the care home premium, which has gone up this year to £133.15 per bed compared to £130.23 per bed last year. Investment and Impact Fund, which is the PCN equivalent of QOF, and the amount payable is dependent on achievement, but there remain to be 58 achievable points at £198, so no change to last year or the year before. So at PCN level, restrictions on use of Rs funding to recruit recently qualified GPs has been removed, meaning access to a wider range of GPs via the scheme. The maximum amount that PCNs can claim for GPs employed via the Rs will be increased to reflect this change, and the national GP reimbursement rate increases from £105,882 to £152,900, and the restriction limiting eligibility to newly qualified GPs within 2 years has been removed. The only remaining restriction is that the GP must not have been substantively employed at a network practice within the previous 12 months. And they have clarified that this does not include temporary maternity or sickness cover. It's also worth noting that this calculates as £118,759 gross plus on costs for a GP who is in the pension scheme. PCNs are now able to recruit non-direct patient care roles if agreed in advance with the Commissioner. All of the Rs roles rates have also been increased, as mentioned earlier. I think I've already also mentioned that there is the new requirement for PCNs to ensure that eligible residents in aligned care homes are identified and offered those seasonal and routine vaccinations in line with the national recommendations. And as I said earlier, this will not necessarily mean that PCNs are responsible for administering the vaccinations, but they must ensure arrangements are in place to offer the vaccinations. So the network agreements have been updated to remove the existing exclusion of flu and COVID-19 vaccination from collaborative delivery under the network contract DES. Should practices wish to collaborate to deliver the seasonal vaccination enhanced service, they will be able to do so under the network contract DES. Amending cancer requirements in the network contract DES, so PCNs must now review referral quality against NICE guideline 12, strengthening and standardising safety netting, including the use of electronic tools, and setting out clearer responsibilities for proactively identifying and supporting eligible patients to engage with cancer and non-cancer screening programmes. 2 screening programmes have been added, that's NHS lung cancer and a group of non-cancerous programmes covering diabetic eye screening, abdominal aortic aneurysm screening, and antenatal and newborn screening with signposting via the NHS app. The existing breast, cervical and bowel cancer screening requirement remains, but with an expectation to understand the barriers to uptake. PCNs must identify and prioritise cohorts for continuity of care as part of their core activities, and this will make continuity a core expectation and support building and embedding more meaningful continuity models as we move forward. Neighbourhood working is obviously the key thing being worked on, so no surprise that updates include requiring PCNs to work with their ICB to achieve greater alignment between the PCN registered list and the neighbourhood. They're not looking at widespread reconfiguration of PCNs. Reconfiguration is only expected in limited circumstances, and the idea is to use 2026-27 to review configurations and start working towards any changes and community working. So it's absolutely essential that practices and PCNs look carefully at their current and future strategies, particularly with regard to time and resources. Collaboration and preparation is key. And again, as I mentioned earlier, it is essential when looking at how you are going to collaborate that you do involve specialist accountants and solicitors very early doors to make sure you get that all set in place in the most efficient and effective and regulated way possible. So let's move on to some more topical issues practices and PCNs face. So national living wage changes impacts you all, and this slide shows this year's increases. Some hefty uplifts again to factor into your budgets, along with the knock-on impact to other pay increases. Another thing to be mindful of is that there have been a few inspections recently, and HMRC have been looking at weekly salary multiplied by 52.143 weeks, not 52 weeks, before dividing by 12 for monthly payments to ensure payments do not fall below minimum levels. So just something for you to check there to make sure that you are compliant. And the next section, for anyone who listened last year, is very similar because it does still stand. So I am just going to whistle through the headlines, all really important reminders, a whole webinar really in its own right. So I am just going to touch on each of the sections just as a refresher and a reminder. We all have good intentions, don't we? And I think sometimes just highlighting those and bringing them to fore they certainly remind me, making a few notes of things that I should be doing. That's always on that to-do list. So the highest proportion of a practice's income is the contract income. Generally over half of a practice's income, and the rest is made up of QOF, enhanced service income, other NHS income, other non-NHS income, rent reimbursements, or notional rent. So what do you need to be doing? Well, firstly, for anyone not preparing budgets or forecasting cash flow, you really need to be, or asking your accountant to support you with that. It is essential for practice cash flow that you are monitoring these so that you can react in plenty of time if there are likely to be any pinch points. Many partners in practices are having to review their drawings levels or take cautiously and have bonuses at the end. And in some practices, not many, but in some, we do still see a lack of understanding that any shortfall does have to be covered by the partners out of their drawings, as it is ultimately all their own money. Preparing budgets and forecasts also helps you to keep on top of cash flow issues, such as the numerous problems we see with salaried GP pensions, for example. Other things that you can be doing to help is ensuring team education. You need to make sure that you are communicating with your team. They need to be aware of their impact on the finances. And this can be from ensuring the right person is doing the right job, correct signposting, full awareness of financial implications of whatever role they play. So, for example, clinical team that are performing services that you claim for, are they aware of what they should be coding and the financial implications if they miss anything? We've already talked about QOF and the importance of coding correctly, being aware of changes of prevalence and personalised care adjustments. You need to make sure everyone is aware of the correct up-to-date codes needed, especially where you have temporary staff and the templates aren't automatically updating. Also ensuring claims are submitted as required. Are the finance team aware of what has been claimed to enable them to ensure the money comes in and is correct? Remember, there are deadlines on back claims for a number of income streams. I've done training sessions with practice staff, and it's amazing how many haven't been aware of the financial implications of their actions in respect of coding. Make sure you code everything too. We will cover some more on income in a minute. Also make sure if any staff are off sick that you have that cover and people who know what they should be doing in the usual people's absence. Patient education is also important. Be open and honest. Everyone wants to, or should want to, support their local surgery. So you need to be talking to them about the support that you need, making sure they attend flu clinics with you rather than pharmacies, because this should really still be a good source of income if it is dealt with efficiently and effectively. Communicate information to your patients that may help them understand things, for example, why they don't always need to see a doctor, what they can do to help you be more efficient so that you remain viable and are still there for them. Are you charging for everything that you can in respect of private fees? And is it an appropriate rate? When was the last time you reviewed those? When you have your notional rent review, get it checked. Don't let your GPs automatically sign and agree it. Which we have also seen, and missing out on potential uplifts. Are you providing any services that you're not getting paid for providing? If so, why? Is there a good business reason or a good patient reason? And if not, could this work be replaced with work that you can get funding for? meeting clinical targets and QOF targets, effective use of resources, ensuring all team are fully utilised. If not, what income could they be generating? Can you cover a number of patient issues in one visit and create efficiencies? Purchasing effectively. So this isn't necessarily looking for the cheapest, this is looking for the best value for money, and consider where you cut costs and the knock-on impact. Don't cut costs in areas that can add value or that may cause you issues further down the line. And a classic example would be not to cut costs on partnership agreements. Get them done properly. They may need to stand up in court one day. Hopefully not, but it does happen. Other issues, cutting costs on accountants and using ones who have no experience in NHS pensions, leaving partners with incorrect pensions and causing huge cash flow problems. This is something we've experienced when taking on practices who have previously had non-specialists, resulting in far larger costs down the line to sort it all out to ensure correct pensions are being received, but ultimately, hopefully, in the future, resulting in the correct and much better pension than otherwise would have been received. Effective communication with patients, again, what is the quickest and cheapest option, but ensuring it's in line with the patient's abilities. Then a few reminders around drug profits, and that can be for dispensing and non-dispensing practices, especially as there are declining refunds and fluctuating dispensing fees and increasing drug costs. So I've just woven in some tips and hints here. So for dispensing practices, are you maximising your dispensing patients? For all of you, make sure with PA claims that everything used is recorded so that it can be claimed, that everyone is aware of what can and can't be claimed. So an example would be sutures. Certain sizes are claimable and certain not. And beware of pessaries too, not all are claimable. So make sure you are buying and using the ones you can claim and recording the correct ones. Make sure you are splitting out claimable and non-claimable items in your accounting software so that you can accurately monitor overall profitability. Do you have a method of checking each month? Make sure the team know on the larger items at least what the refund rate is each month and ensure that they're buying at a rate that will make a profit. Don't forget to take into account any discount and also VAT. So Morena's, you actually only pay 5% VAT on, but PPA refund 20%. So taking quirks like that into account. If you won't make a profit on a certain drug, is there an alternative that you will? Don't forget to spread scripts out across doctors so you don't lose out on dispensing fees with it being a sliding scale. Be savvy with your dispensing fees, which are based on items dispensed. With flus, don't order late and get charged extra. Remember that sale and return is limited now, so don't over order, otherwise you will be trying to sell on to get some money back. Don't over order any other stock that may risk going out of date and having to be disposed of. Be aware of supplier premiums. Convenience can be costly. Higher cost drugs require more attention as they can tend to be loss-making and also can soon impact if any become out of date if you no longer need them because you've ordered them for a patient, for example, that no longer needs them. Prostat can be really profitable as it attracts the most discount, but only with one supplier, according to Ash Lane. So really do look closely at discounts when reviewing costs as well. Be really careful with flus and make sure the person claiming looks at the box to make sure there's no risk of incorrect claims that can also be costly. On the topic of flus, some more tips and hints that have been going around is not to trust the flu supplier's forecast of profit. Calculate it yourself and don't go for the cheapest flu vaccine necessarily. Go for the most reliable supplier as any delays in delivery will cause losses. When doing your flu campaigns, look at how they are delivered. What else can you be doing whilst you have the patient in to make processes even more profitable? And obviously with the joint COVID and flus this year, look carefully at that. Make sure that the number of flues claimed corresponds to the number of flues purchased and used. There have been a few occasions where we have seen this is not being done, and there have been underclaims. It is easier to monitor and deal with any issues at the time than trying to arrange a back claim. There may be items that you just can't make a profit on. So consider writing a script for those. I appreciate that will depend on where the nearest pharmacy is and impact on patients. But ensure scripts are correctly completed as well so that you don't lose money on script fees. And you can consider outsourcing checking of drugs income, as it currently passes through so many hands in the practice and PCSE. So there are businesses out there that will run checks and have access to necessary IT links that can support with that. Of course, the other issue here is the dispensing fees keep moving, and sometimes quite significantly. For any practices who wholesale, it's really important to try and ensure wholesaling costs are also coded separately, as it does make it very difficult to ensure your regular surgery claims are as profitable as they should be if the figures are all muddled together. So your biggest cost, unless you're a dispensing practice potentially, is your staffing cost, including locums. And as I mentioned earlier, when we were talking about the staff increases within the contract, there will still be winners and losers in respect of the uplift versus the cost of staffing cost increases, depending on how your practice is structured. So careful consideration is needed in respect of salary increases to balance affordability and retention of good team members. So you need to be reviewing contracts, particularly around overtime rates and sickness policies, in respect of how that will impact your finances, but also consider job roles and duties. Cross-skilling your staff to assist with holiday and sickness cover, for example, and planning holiday and cover well in advance to aid the cost of cover. The sooner you can get the team to agree holiday dates, the more likely you are to be able to ensure you have sufficient cover in the existing team as much as possible without incurring too many additional costs. I appreciate, though, that does depend on roles. The more time to plan, the more cost-effective cover usually. And the use of R's roles is really important. So back in 2019, we obviously saw the introduction of the PCNs, and GP practices were really pushed to join or risk losing funding. And these were to group practices together to achieve the benefits of working at scale, look at more efficient working by working together across practices with community services, and to reduce health inequalities. And it was aimed to give the ability to hire additional team and manage escalating workloads. Funding has been focused more towards the PCNs rather than the individual GP practices, even though there obviously has been some shift back with the capacity and access this year. But you do need to continue to make sure you are aware of what is going on in your PCN and what you can be doing to maximise your income, share or access staffing. Be aware what is happening in any federations you're part of as well. And if you are one of the practices listening who are part of an active federation, with PCNs and federations, talk to them, work with them, make sure you're getting the most out of them. I know there are some fantastic ones out there that really support their practices. Equally, we have seen on occasion some pretty shocking scenarios as well. This year, with the plan changes from 2027, it is essential to be working closely to be in the best position as neighbourhood working evolves. One other mention there is, as I've mentioned before, business cost consultants. They don't cost anything, but they can save you a lot. It is worth having a chat to see if there are any fairly simple wins out there for you with your costs. One thing I haven't discussed in this webinar are area specifics around how enhanced services are paid locally, because there are various people from various areas on the webinar today, and so different methods of payment. But you do need to ensure you are aware of any of the local changes and how they impact your practice and the cash flow as well. There are differences in local funding across the UK for some of the enhanced services, so be aware of any local incentive schemes or available one-off funding. And finally, a few hot topics. So again, really quite long topics on their own. So just to flag and enable you to raise any questions. So we have the McLeod judgment. There is a lot of work required around this, as the annual allowance tax, super and contributions, and tax relief on contributions all need considering. There are various scenarios where compensation has been agreed for professional fees in respect of the calculations that will be needed, but this is capped. Our pension team has been very busy working on these, and if any of your partners receive any annual allowance letters from NHS pensions, please do forward them or ask them to forward to us, as we don't automatically get copies. And for anyone listening who isn't a client of ours, you forward those to your accountants or whoever is looking after that aspect of pension work for you. Not everyone will have received their RPSS, so their remediable pension scheme statement yet, particularly those where there are issues still with their record. Hopefully NHS Pensions should start producing the annual allowance growth statements for 2024-25 in the near future. Again, please ask your partners to let us or your accountants have details of those. Where they hadn't yet been sent the 23-24 statements, they may well receive both years at the same time now. As NHS Pension have been reviewing service records, there have been a lot of PCSE cases opened requesting certificates, and these must be updated in order for any partners impacted by McLeod to be able to receive their RPSS. So we need partners to ensure that they are not ignoring any emails they receive from PCSE in respect of missing certificates. There are also many salaried GPs who had not completed their Type 2 certificates, and we've certainly been supporting quite a few with this. Their records can't be updated if they have older years outstanding. And some of the cases we've picked up have involved a number of years certificates being prepared, so we can support salaried GPs with that if anybody needs us to. And as a practice for you, it is really important that they are completed so that any balances, particularly arising due to a different final tier rate than had previously been used, can be dealt with efficiently and effectively, and hopefully while those salaried GPs are still in the practice or contactable at least. Notional rent reviews, I think I actually mentioned already earlier on, just a reminder to remind practices not to just sign off the notional rent review. It really is worth getting a second opinion or at least having a quick initial chat. We often see surveyors finding practices some more money. NHS sickness claims, I did actually already mention that as well as I was running through, just to remind you that you can claim for GP partners or existing GPs in the practice as long as they're not working full time, doing extra sessions, that can be invoiced across as well. It is still a question that we get asked. Then we've got Making Tax Digital. So Making Tax Digital was originally announced in 2015, and it was intended to be fully implemented by 2020, but then was delayed. From April 2026, self-employed individuals, so this includes any GPs who are sole traders and landlords earning over 50,000, will be required to maintain digital tax records that are MTD, so Making Tax Digital compliant, and submit updates every quarter. So you will have to ensure your data is well analysed on a compliant system and up to date every quarter for submission. I know there are very few, but some practices do not use their software to its full potential, as they perhaps use spreadsheets sitting to the side, and those practices are going to have to be up to date with their bookkeeping and analysing data efficiently on the system. So currently just sole traders, but partnerships watch this space for a date. The 50,000 is based on submitted 2024-25 figures, and we have written to all of our clients who will be affected. But if anyone has any questions, please do contact us. Tax will be paid as normal, January and July, and there will be 4 quarterly submissions and also a final declaration that you'll be filing. I'm sure the move will eventually be for some money to be changing hands more than twice a year, but we'll see what comes out. So the first Making Tax Digital submission is due to HMRC on the 7th of August, and that's going to be reporting on the quarter from the 6th of April 2026 to the 5th of July 2026. Subsequent submissions will be due on the 7th of November, 7th of February and 7th of May. And finally, a few more reminders. So PCSE and superannuation issues. So some of the current bigger issues have arisen since PCSE tried to make it easier for practices, partners and accountants by giving accountant access. Unfortunately for non-GP partners, there is a very big glitch in that. If they give us access, they lose access to everything. So PCSE are working on this, they are aware. And in the meantime, it has been suggested, and PCSE have put out an email to suggest that partners revoke access for accountants for now so that they can continue to access their records. There are also access issues where a partner has retired or opted out. And whereas we could see former partners for each individual practice and advise on balances, we can no longer see those either without the former partners giving us permission. So a few steps forward and quite a few steps backward, it feels at the moment. We've got our ASMA conference next week, and PCSE will be attending to give us an update, so watch this space. Continue to be issues, not so many, but there do continue to be some issues with joiners and leaver forms. There is detailed guidance on PCSE website of the process required. The leaver process is straightforward and can be actioned by the practice, but the joiner process relies on various steps, from the GP joiner updating the performers list, the practice confirming and completing the joiner form. Estimate of superannuable profit forms, don't forget to update these throughout the year, or advise your accountant if they do, for any in-year changes in salary for salaried GPs, as well as joiners, leavers, people opting in or opting out, and any changes to partnership profit shares. A reminder that PCN profits for inclusion in practice accounts, they are needed for inclusion in practice accounts. Remember, the profits from the incorporated part of a PCN do need declaring in those member practice accounts. So if they can be obtained before completion of the practice accounts, that is very, very helpful. New pension tiers and pay rises. So this is a reminder to be mindful of pension tiers for staff and salaried GPs when giving pay rises. Not quite such the jumps that we'd seen a few years ago, but just £1 into the next tier gives them no more pension, but they have to pay the higher rate tier on all of their income. So just a note to watch where they sit in respect of tiers. Also watch, or remind them to watch, if they do an extra session or so, if they are close to the threshold. Of course, you don't always know what they're doing outside that can impact on the tiers as well, but just something to flag and maybe have a discussion about. GP earnings declaration. So this is the website one, the ridiculous and meaningless figure that still has to be calculated and declared on your websites, which we keep hoping they will dispense with. But at least the declaration of GP earnings for individual GPs based on the superannuable earnings has been abolished. So that was one good thing. Partnership agreements, another reminder of how important these are. Make sure that they are up to date and accurate, and use a medical specialist solicitor. We have seen issues where a specialist hasn't been used. I have seen a practice trying to amend one themselves as well, and I really wouldn't recommend it if you are going to need that to stand up in court at a later date that nobody expects to, but unfortunately there seem to be 1 or 2 cases floating around this year. I have just got, not on the slide, sorry, but just 1 or 2 other items to note on there. So premises, so leases, there is a minimum number of partners that have to be listed on a lease. And if you are going to have partnership changes and the numbers go below that number, just need to be mindful of checking what that number is, and if any changes like that are likely to impact you. Where you own your property, don't forget to keep the title deeds up to date. It can become a costly problem to change at a later date, especially if a retired partner has passed away. One issue we have seen as well is delays on repayment when a partner leaves a practice. So if you can make sure the partnership agreement is up to date, and clearly states what needs to happen when anybody is retiring or leaving the practice. It just makes it so much easier and clearer for both parties to know what to plan for. So we will be running a few free webinars throughout the year again, as we usually do. So please do watch out for those. Thank you so much for joining me this morning. That is the end with 5 minutes to spare. And I am just going to look. There doesn't appear to be anything in the Q&A section at the moment. It's just loading, but there's nothing flagged. I have popped my email address in there, as I say, for anybody that doesn't already have it. So if anybody does have any questions, please do feel free to just pop those in the chat. It's all very quiet. Like I say, you can also email me directly, or there will be a feedback form. Speaking of which, it's really, really helpful if any of you have got any topics that you would like to see covered. Stop sharing my screen now. It is really helpful if any of you have got any topics that you would like to see covered. If you can let us know, it helps us to know what you'd like to hear about, and we can look to put any of those on. Okay, there doesn't appear to be anything popping up in the Q&A. So, what is the minimum amount of GPs required for a lease? Generally, you would have a minimum of 2, but you do just need to have a look at your individual GP, your individual lease agreement, because it may be that it's different to that, but generally you would have a minimum of 2 on there. But like I say, just check your lease, your personal lease agreement though. Okay. Well, thank you once again, everybody, for attending. And yeah, please do be open and honest with the feedback if there is anything we can be doing or doing better, and anything you would like to see. Have a lovely rest of the day. Oh, I've just got a message to say there might be a second question. It's not popping up on my screen yet. Ah, there we go. Right, it's just popped up now. It's obviously my colleague can see these popping up quicker than me. So when a partner leaves, mostly you will find that the partnership agreement will say if a partner's left partway through the year, so most practices are a March year end now. If a partner has left partway through the year, usually accounts would still be produced to the 31st of March, and adjustments would be made to cater for any significant income or expenditure that doesn't run smoothly through the year. And most partnership agreements will say that any final balance needs to be paid within a certain number of months after the accounts have been finalised and agreed. Quite a few partnership agreements would state that the accountants would look to estimate what payment is likely to be, particularly if you've got a practice capital account. So where we've got a capital account where you've invested money to buy into fixtures and fittings, or put cash into that practice capital account as well to fund working capital, and there'll often be a clause to say that you would make a payment on account of that, which can be anything from 50% to 80% of that as a payment in the interim until final accounts are prepared. I hope that's helpful. They're popping up now. A bit more about business savings experts. Yes, so actually a number of years ago, the business savings expert that the cost savings gentleman that we used for our firm actually went out to quite a few of our practices and were looking at in particular things around utility contracts. So your gas, your electric, telephone. There are a number of things that he would look at, but I do recall one practice where he made annual savings of 13,000 a year, which did incorporate their utilities contract as well, but they did make quite significant savings. So I do have his details, and there are still practices that use him. I'm aware in some areas there are other people, but I'm happy to send his details across if you don't have details of one and would like to. Doesn't cost you anything, so you're not going to lose anything because, as I say, they're not paid. They have usually agreements with the suppliers that they're moving to that sits outside of the savings that you're going to make. Super, thank you. Okay, I think that's all of the questions that have popped up for now. So as I say, please do feel free, if you do think of anything else today, tomorrow, next week, feel free to drop me an email if you have got any other questions that I can help with. So thank you very much, everybody, for joining, and hopefully I'll see you all at the next webinar that we run. So look out for any events on the website, and thank you for attending.